First, a few general questions to the panel, and then we'll get down to what I hope will be a most interesting specific discussion of the management of acute withdrawal syndrome. Dr. Knott, do you believe that the alcoholic at present, especially the alcoholic in withdrawal, is being adequately treated in our society?
No, Dr. Cohen, I do not. I think this is largely a result of ignorance and subjectivity on our part concerning the physiologic effects of alcohol. However, I think as we obtain new research data and become more objective about the pathophysiology of alcohol and its withdrawal, we are becoming, and indeed will continue to become, more effective in the medical management of these patients.
Dr. Beard, from the physiologic point of view, what do you feel is the most important item that we might stress to the physician?
Dr. Cohen, I believe that a critical problem is that of fluid and electrolyte metabolism. At present, most alcoholics are being treated as if they are dehydrated. But as we shall see very soon, the overzealous use of intravenous fluids may be contraindicated because many of these patients may actually be overhydrated.
I see. What about you, Dr. Fox? How would you state a position regarding the most important aspect that you consider to be vital in the management of such patients as we're considering?
Dr. Cohen, I believe that the attitude of the people who are treating the patient is of paramount importance. If they are genuinely concerned and if they are confident of what they're doing, much of the patient's terror and anxiety is relieved.
Mr. Stern, we depend on you for the important legal aspects of our present problem. What are the traditional attitudes toward the alcoholic, the drunk, if you will?
Dr. Cohen, the traditional response of the law has been the passage of local and state laws making it criminally punishable to be drunk in public. These laws have not been enforced equally. They have been enforced primarily against the Skid Row population or the slum area residents. And as a result, a good deal of detoxification and withdrawal takes place in the jail, where there's a complete absence of social and medical care.
Dr. Beard, you mentioned something which I think is of deep interest to all of us, namely the mismanagement of the alcoholic who needs substantial medical treatment with regards to the electrolyte and water balance. Would you expound on this a bit?
On one hand, alcohol certainly is known as a diuretic, and the mechanism whereby the alcohol diuresis was promoted was explained in about 1938. Prior to that time, alcoholics were treated as if they were overhydrated. But since 1938, intravenous fluids are usually one of the most early forms of therapy that is started upon the admission to the hospital. It is important to note that the only time a diuresis results following the ingestion of alcohol is as long as the blood alcohol level is rising. Thereafter, once the blood alcohol level has plateaued or begins to fall, an antidiuresis ensues. Consequently, what we have found in well-nourished chronic alcoholic patients is that indeed overhydration is much more common than dehydration. It is also important to recognize some of the changes in electrolyte concentrations that occur within the neural tissue. Normally, there is an increased amount of sodium within the cell and thus a decreased amount of potassium. In essence, this in itself, by reducing the membrane potential, can make the patient much more irritable, much more excitable.
I think the research data which Dr. Beard has delineated has some important clinical implications, Dr. Cohen. In the first place, very often diuresis of the acutely withdrawing patient, especially if he presents with edema, is a useful therapeutic adjunct. Something that is often used in admitting wards and in emergency clinics dealing with the acute alcoholic is the clinical sign of dehydration known as the dry mouth. Now, almost all alcoholics, acutely withdrawing alcoholics, will have a dry mouth. But seldom is this on the basis of dehydration unless there's been vomiting or diarrhea. Most of the time, the dry mouth is on the basis that alcohol and or its metabolites, in part, is being excreted via the lungs, and as a vapor, it dries the mucous membranes, thus giving the sensation of a dry mouth and thirst, although it certainly is no indication of a total body dehydration.
I wonder whether we shouldn't ask the panel something about the presenting symptoms of the withdrawal state. Would somebody like to volunteer an answer to that one?
The acute withdrawal syndrome, per se, is usually a progressive phenomenon. It starts with the shakes or psychomotor agitation. There's often tachycardia, systolic hypertension, a flushing of the face. This is the first stage. If it is to progress, it will go into the second stage of hallucinations, either visual, auditory, or tactile, or all three. The third stage is that of delirium, delusion, disorientation, which can be intermittent and transient in nature. If we add to it the final stage, that of seizure activity, and it need not be grand mal seizure, but just seizure activity, this is DTs, this is delirium tremens, and is a syndrome for which we have not had a great deal of success in regard to its treatment.
One thing that I've often wondered about, and Dr. Fox, you've had enormous experience with people in this state. I wonder what your opinion is to this point. How long does it take a serious alcoholic to have his first episode of DTs? What is the shortest interval, would you guess?
I have actually seen patients in fairly mild DTs after as brief a period of time as 2 weeks of drinking. But they were usually people who were otherwise chronically disabled. For a person who had not these other difficulties or acute trauma, I think it usually takes several months.
This brings up the whole question, I suppose, of who is predisposed to the more severe forms of the acute withdrawal syndrome. And let's mention some of these. Dr. Fox, do you want to start off?
Well, certainly the older patient, the patient with other disabilities, the patient who is suffering concomitant acute insults such as accident or surgery or pneumonia, people who have prolonged drinking histories, these are the individuals that are subject to the more severe withdrawal syndromes. But again, they are not exclusively the ones who are candidates. Otherwise, fairly healthy, relatively young individuals can become quite toxic from exposure to extremely large amounts of alcohol, even over periods of time as short as 3 or 4 weeks.
Would anybody like to add to that list that we've started on people who easily go into this syndrome?
Dr. Cohen, I'd like to add one thing. It is amazing that there are so many people that believe that if you're a beer drinker or a wine drinker, that you really cannot get into any difficulty as far as the acute withdrawal syndrome or full-blown delirium tremens. I think this is absolutely absurd. We speak so often of the denial of the alcoholic, but when we look at the drinking American, we see possibly even much more denial.
Perhaps to reinforce what Dr. Beard said, that there isn't any particular alcoholic beverage that will protect one, so to speak, from acute withdrawal syndrome. We have seen severe acute withdrawal with beer drinkers, and certainly I personally feel that the wine drinker is one of the most difficult medical problems that faces us.
I think there's something else that we're extremely prone to overlook. Mixed drug and alcohol intake can greatly enhance the severity of the withdrawal syndromes. In our experience, this is an increasing problem. In many ways, it's difficult to pin down because the individual is frequently taking a major tranquilizer or mild sedative during the day, drinking in the evening, and then taking a sedative, maybe barbiturates, maybe one of the others, at night. It's more than just the addition, it's actually the synergistic effect of the total intake of sedatives on the brain in each 24 hours can be quite devastating and quite tricky clinically because the alcohol withdrawal syndrome manifests itself predominantly in 48, 72 hours, then the other withdrawal syndromes are superimposed at 5 and 6 days.
Now let's go into the question of the differential diagnosis of alcoholic withdrawal syndromes. Dr. Knott, Dr. Beard, who would like to take a crack at that one?
One diagnosis that is often made is a diagnosis of alcoholic hallucinosis. Now, while this is largely felt to be primarily auditory in nature, nevertheless, this represents really a spectrum. And some of the important differential points between an alcoholic hallucinosis and the acute withdrawal syndrome per se would be, for instance, in the hallucinosis, the sensorium is clearer than in the acute withdrawal syndrome. The patient is less agitated. Often there are no signs of autonomic hyperactivity, such as tachycardia, systolic hypertension. There is less agitation, and there is little or no amnesia concerning the hallucinating experiences. The patient can remember them well, and often they're not threatening. And in the acute withdrawal syndrome, the hallucinatory experience is almost uniformly threatening. Now, whether this represents simply a milder form of the acute withdrawal syndrome, whether the alcoholic hallucinosis is a manifestation of something superimposed on a psychotic process like many people think, or whether it is a diagnostic entity in itself, I think there is still a good deal of confusion.
One thing that impresses me is that barbiturates, non-barbiturate hypnotics, and certain tranquilizers can, when a person is dependent upon them, can in themselves produce a withdrawal syndrome, sometimes mimicking the DTs from alcohol remarkably well, and the only difference you can discern is that they don't smell of booze.
The alcoholic has an increased tolerance to the barbiturates. It takes more of the barbiturate to produce the desired effect. And one thing that the attending physician should keep in mind in regard to the use of barbiturates in the alcoholic is, first, it is inherently dangerous to prescribe, even on the acute basis, barbiturates in the alcoholic. But if such compounds are to be used, remember that the shorter-acting barbiturates are metabolized in the liver. The acute alcoholic has an impaired liver function, and thus the shorter-acting barbiturates are to be discouraged, as opposed to the long-acting ones that are excreted primarily via the kidneys. And this whole aspect of alcohol and combined drug abuse should be a warning to the physician that if a psychotropic is used in the treatment of the alcoholic, either in the acute phase or the follow-up care, extreme caution must be taken in choosing those agents which are relatively non-habituating and which do not show the synergism with alcohol that many other agents do.
Dr. Beard, I'd like to ask you to give us some more information about the pathophysiology of this condition. I realize it's enormous, but could you summarize the highlights for us?
Very briefly, I think that attention should be paid also to the cardiovascular system, especially during the acute withdrawal syndrome. It has very recently been pointed out that alcohol itself is cardiotoxic. It reduces coronary blood flow, it decreases the contractility of the myocardium, and it actually produces cell death to the myocardium. Very often, what is very easy to produce in the experimental lab is that of a fatty heart, not the association of alcoholics with beriberi heart disease. Anemia certainly has been recognized in the alcoholic population for many years. But here again, it has been explained on the basis of malnutrition, a lack of vitamin B12 and/or folic acid. It has now been demonstrated that alcohol itself exerts a toxic and depressive effect upon the bone marrow.
The incidence of peptic ulceration in the alcoholic is greater than in the non-drinking or non-chronic alcoholic population. Therefore, he is susceptible to bleeding, and of course he's susceptible to those conditions caused by his alcoholism, esophageal varices, for example, that bleed very readily.
You might add that bleeding hemorrhoids are an extremely common difficulty with the chronically heavy drinker.
Dr. Fox, do you have any opinions as to when these people in the abstinence syndrome should be hospitalized, when they could be treated at home by the physician, and so forth?
When the individual has, for instance, question of bleeding, when they are disoriented, hallucinated, or convulsing, if they have other serious injuries or illnesses that need care, obviously hospitalization is indicated. There's also a problem that always bothers me in practice, and this has something to do with the legal aspects that I'd like to ask Mr. Stern about. If a patient is extremely intoxicated, belligerent, doesn't want to go to the hospital, but I feel that it is very much in his best interest to go to the hospital, where do I stand in terms of my responsibility? On the one hand, to take care of him. On the other hand, I have no real right to almost kidnap him. I'm talking about a day or two or three.
There's a good deal of legal thinking in this area that says that even insofar as 2 or 3 days civil commitment, there must be some legislation, some civil authority enabling you to seek his commitment even for short term.
What about the opposite side of the coin? Namely, the man is now recovered mentally. He is oriented and considered competent. He is, however, bleeding severely from the gastrointestinal tract. We believe that his life is in danger if he were to leave. He insists upon leaving. Where does the doctor stand?
I believe that man can leave the hospital. And I say that from a legal point of view and a moral point of view. I think the man should leave that hospital.
Mr. Stern, I have somewhat more of a general question. I'm becoming increasingly distressed concerning the disease concept of alcoholism and what this implies for the medical profession. What is your opinion concerning, from a legal point of view, the disease concept of alcoholism and our responsibility in that regard?
I think the disease concept of alcoholism, as manifested in recent court decisions, will pose quite a problem to the medical community. I think now, therefore, now is the time to act. Now is the time to commit more and more resources to enable the medical community to treat this problem. One of the dangers of the disease concept of alcoholism is that once we begin thinking about alcoholism as a disease, in many cases, particularly in the case of the Skid Row alcoholic, we begin thinking about involuntary civil commitment. Now, if we remove this problem from the criminal courts and thrust it upon the medical profession in the guise of a disease, we know that there will continue to be a great desire to remove this person from the streets, and we will probably be building hospitals as jails or creating jails out of our hospitals.
You know, it concerns me somewhat when we get preoccupied with the question of enforced treatment. My experience has been that the more available and the more appropriate you make treatment and programs to patients, the more they're going to utilize them, and the solutions are largely one of making treatment available rather than worrying too much about forcing people to use it when it's there. I think if we ever learn to communicate with the patient where he is and reach him with his acute and chronic brain syndromes and offer the kind of services that will help him, then we won't have such a big problem of worrying about how to force him into treatment.
I would just like to twist that around a little bit and say that I'd like to see more concern for making such facilities available and not be so concerned with constructing involuntary kinds of programs. I don't think we've done enough in establishing voluntary programs. And I would hate to see a beginning of getting into civil commitment programs without an honest effort in building voluntary programs.
Well, let's get to another most important aspect of our subject, and that is, how do we manage the alcoholic in acute withdrawal? Dr. Knott, why don't you start off with some of the concepts of proper management?
Well, when one considers initially the management of the acutely withdrawing patient, the first thing that usually comes up is the use of a psychotropic drug or sedation. The difficulty in the past has been that we have had a tendency to over-sedate the patient. This obviates are being able to evaluate him, make the proper disposition, and has led to a number of fatalities. There have been recent publications somewhat extolling the virtues of paraldehyde and chloral hydrate. And while in many instances these compounds work, I would caution the physician of the inherent dangers. Paraldehyde is hepatotoxic itself, and the synergism between chloral hydrate and alcohol have long been recognized. We feel rather strongly that the minor tranquilizing drugs, as opposed to the major tranquilizing drugs, are of greater benefit. Ideally, the drug that is employed should be non-habituating or non-dependent producing. It should not be hepatotoxic itself. It should not compromise cardiovascular function. The cardiovascular system of these individuals is quite labile. They are subject to hypertension, hypotension without any drugs. It should not produce excessive sedation. See, what we're faced with these people is having to develop a rapid, safe, effective means for detoxification so that we can deal with the problem. Should this patient come into the hospital, should this patient be sent home and seen tomorrow, for instance, on an outpatient basis, or should we keep him here for another 2 or 3 hours and watch him? Obviously, we're not going to be able to hospitalize all acutely withdrawing patients that we see. We don't have enough hospital beds. And consequently, we must take this approach, and so a drug should not produce excessive sedation. If the patient goes to sleep, we can't evaluate him. The drug should not complicate a neurological exam on a serial basis. A minor tranquilizing drug doesn't cover a psychosis. Now, this is extremely important because many people that we see in an emergency situation may be paranoid schizophrenic and they are acutely withdrawing. And I feel strongly that the management of this patient later, after the detoxification effort, is extremely important and is different from what we will call the alcoholic.
I have a couple of questions to ask of you in this connection. One, I assume then you do not approve of the use of alcohol in the treatment of delirium tremens. Is this correct?
Absolutely not.
And why are you so harsh on the phenothiazines?
Well, of course, they are a prototype of the major tranquilizing drugs. Many phenothiazines themselves will increase a seizure diathesis, will tend to promote convulsions. Many phenothiazines will also cause rather severe postural hypotension in many people, and many phenothiazines are hepatotoxic, and this is above and beyond the hypersensitivity phenomenon that we associate with drug hepatidities. This is
On the other
inherent
hand,
liver toxicity.
On the other hand, many phenothiazines are antiemetic, which is a goodie. They are not addictive or dependency producing, which is an advantage, whereas some of the minor tranquilizers can be substituted by the alcoholic as a drug dependency rather than an alcohol dependency situation.
Oh, I agree. And thus I think the selection of the drug is extremely important. There are many of the minor tranquilizing drugs that have a tendency to produce euphoria and thus are substituted for alcohol or taken with alcohol. However, there are some minor tranquilizing drugs that we feel fit these ideal characteristics, and we can get away from the major tranquilizing drugs. The idea, of course, is to get the patient detoxified as rapidly as possible and possibly off drugs entirely later during the rehabilitation process.
Dave, when you were mentioning overhydration and IV fluids as frequently contributing to the difficulty, we also see a fair amount of difficulty by increasing the respiratory alkalosis with the overuse of oxygen during the first 2 or 3 days of withdrawal.
Yes, most patients are hyperventilating anyway when they come in, and even the anxiety associated with withdrawal and hospitalization can tend to promote hyperventilation, and they can get into some acid-base difficulty, particularly respiratory alkalosis, and we have not found oxygen to be very efficacious. In fact, this may be a myth supported by pilots who breathe oxygen at altitudes to help clear their hangover rapidly, but I think oxygen has some side effects in the treatment of the acutely withdrawing patient, and it need not be used to treat the patient properly.
No, most of the patients that I see in that first 48 hours who are complaining of tightness in the chest and inability to breathe respond infinitely better to a substantial dose of Vistaril or Sparine than they do to oxygen by any stretch
And
of
a
the
tender,
imagination.
loving care.
Yeah, a little reassurance is very helpful.
Right.
Well, I'm sure we each have our own favorite sedative for the treatment of the highly disturbed DTer. I don't suppose we have to caution anyone by saying don't use these drugs unless they're symptomatically indicated. Would anybody like to make a further comment on alternative or their favorite hypnosedative or tranquilizer?
I think I have said the drug of choice that we find quite useful is Vistaril, used in not low doses but relatively high doses, 100 milligrams initially, possibly followed within 60 to 90 minutes by another 100 milligrams if this is needed. The problem is this alone is not going to help the patient to recover. In other words, the use of any psychotropic drug alone, I feel, is contraindicated in detoxification. It should be a therapeutic adjunct and should be only a part of the total medical management program, which will include anticonvulsants, fluid and electrolyte therapy, or diuresis, magnesium sulfate, a number of other things that can be included in the medical management of the patient.
One drug that must be mentioned, since in some studies it showed up quite well, is Librium in, again, adequate dosages. In the VA cooperative study, for example, it seemed to do as well as or better than most other comparative drugs that were used.
Well, the difficulty in evaluating the efficacy of a drug is how well the patient likes it. And we have found some difficulty with the use of Librium, not necessarily totally, both acutely, but in the follow-up of the patient in regard to they like it very well. And I am always suspect of an alcoholic patient who likes to take a particular drug. I think we should take a close look at this because, as we have already emphasized, the ability of this patient to either replace alcohol with this drug or especially combine it with alcohol, and this makes it another medical problem.
Could you perhaps tell us something about the very serious problem of major convulsions in the alcoholic? Do you give, for example, Dilantin or phenobarbital for that matter?
Well, as we have mentioned, the alcoholic is prone to seizure activity, petit mal seizure, bizarre seizure activity, in addition to grand mal convulsions. And now we do use diphenylhydantoin or Dilantin regularly and empirically in all patients, not only because we feel that it reduces the tendency toward convulsions in these patients, but Dilantin has a very interesting effect on cell membranes. As Dr. Beard mentioned, alcohol tends to increase intracellular sodium and decrease intracellular potassium. This could explain physiologically the tendency toward convulsions. Dilantin has a specific effect not only on neural tissue, but also on skeletal muscle tissue, cardiac tissue, and so forth. As a specific effect on the cell membrane, tends to restore intracellular potassium and to remove sodium from the cell, thus restoring normal cellular membrane function. And so we feel there's a good scientific basis for using Dilantin, and since we began doing this empirically, we have reduced the incidence of the seizures.
You're certainly on one of my pet subjects right now, and when you threw in Dilantin and phenobarb in context like we couldn't say Yankee as one word and where I come from, I'm firmly convinced that the commonest cause of the first convulsion after age 40 is probably withdrawal syndrome. And I see a great number of patients who have one or two withdrawal convulsions are put on phenobarbital and Dilantin. They usually throw away the Dilantin, take the phenobarbital in as few days as possible, start back drinking, and then have withdrawal convulsions again. And I think it's something we ought to be awfully careful of, putting adults on phenobarbital until we are certain that they're not having withdrawal convulsions.
Gee, that's a good point, because we do also see patients who may have been taking Dilantin and phenobarb for 2 or 3 years, and you take a careful history of their seizures, and it unequivocally was associated with alcohol withdrawal, and apparently, either because of the denial of the practicing physician or the fact that the patient was an unreliable historian, this was not made. And many of the seizures, the majority possibly past this age, and even younger, are on the basis of acute withdrawal, and they don't need to be on long-term Dilantin and phenobarb therapy. Our Dilantin we may use for 2 to 3 weeks, and this is all, and then stop it. because we feel at that time the physiologic balance has been restored and the patient, with few exceptions, is out of danger in regard to seizure activity.
We certainly get good results with the dilantin alone, along with, as you said, the management of the rest of the syndrome without ever using the phenobarb component.
Dave, I would like to hear you comment on the possibility of many times the convulsion itself may be on the basis of hypoglycemia. Many times when the patient is admitted to a treatment center and you determine the blood glucose level, it may be elevated. But if you repeat this determination 2 hours later, it may go from 180, for example, down to 60 in a very short period of time. Would you comment on that?
Right, this is an important aspect, again, of the management of the acutely withdrawing patient. The blood glucose is very labile. Probably alcohol's initial biochemical lesion in the liver is a depleted hepatic glycogen. And this, superimposed with perhaps malnutrition or a poor nutritional intake, makes the patient quite prone to hypoglycemic episodes. Thus, in the acutely agitated, acutely withdrawing patient, we will often give 50 cc's of 50% glucose IV.
You've been talking about the various sedatives that can be helpful in the alcoholic. How about some very specific suggestions to the physicians regarding dosage, Dr. Knott?
Well, when the alcoholic is first seen and our initial drug of choice is Vistariel, we will give 100 milligrams intravenously, follow this within 60 to 90 minutes with another 100 milligrams, usually intramuscularly, and then if the patient is responding and can take PO medication, put him on 100 milligram doses of Vistariel divided throughout the 24 hours. Now, dilantin, we start with 400 milligrams daily in divided doses and gradually decrease this over a 3-week period. We'll give 50 cc's of 50% glucose intravenously. We'll give anywhere from 100 to 300 milligrams of thiamine parenterally initially because we feel that they do need thiamine. These are some of the specific doses of drugs that we use. Dr. Fox, what are some of your doses in the drugs that you use?
Dave, I think our basic concepts and programs are fairly similar, except that I'm firmly convinced that the correct use of relatively small doses of phenothiazines in addition to Vistariel improve the results very significantly, and that the two drugs go together beautifully. For office or outpatient care, it is hands down the most safe and effective drug that I know. For the hospitalized patient, who is usually more sick, I have not found by itself to frequently be enough in the first 48 to 72 hours. In addition to thiamine, we give the rest of the B complex in the first 2 or 3 days parenterally. For a rare occasion, I have seen what I thought was a pyridoxine deficiency convulsion.
Well, now, is the massive use of vitamin therapy a myth, or does it have some substance in reality? Who would like to try that one?
Well, in my opinion, it is certainly not a myth in the first 72 hours of a substantial withdrawal syndrome or acute brain syndrome.
How do you people feel about antibiotics? Should they be prophylactically given to the infection-prone person that we're dealing with, the person who may be malnourished, may aspirate his own vomitus, and so forth? Do you routinely use antibiotics?
I would be reluctant to advise the across-the-board empirical use of antibiotics in all acutely withdrawing patients. However, I would certainly advise the early and aggressive use of antibiotics at the first sign of infection, and certainly our index of suspicion for infection in these people should be high. So we don't use them routinely, but many patients receive antibiotics because we suspect infections, diagnose them, and then treat the infection.
I'd certainly be opposed to the so-called prophylactic use because I think you'd frequently mask the real onset of infection.
Yes, well, I think those are very important comments. I think we neglected to mention before the dosages of Librium, for example, which could be employed. These are approximately the same as those you mentioned for Vistariel, Dr. Knott, and used in the same fashion. As far as those who prefer phenothiazines, the equivalent of 25 to 50 milligrams of chlorpromazine intramuscularly is considered an average dose for a raging person in delirium tremens, this may have to be repeated rather often until the person is quieted.
I would like to go back and take some serious exception to, for instance, a dosage of Librium or Valium of 100 milligrams every 4 hours over a 3 or 4 day period and then discharging the patient to home. I've seen it too frequently that when he got home, he then had to go through the withdrawal syndrome all over again, and more often than not wound up back drinking. And this would be a hospital procedure that I would seriously question. A few doses in the first day or two may be one thing, but to continue large dosage right up to the time of his discharge, I think is doing him a disservice.
I think one compound, Dr. Cohen, that we have overlooked, that from a physiological standpoint would seem to be very important to managing the patient, and that is magnesium sulfate. There's no doubt about it, in the drinking population, or especially in the acutely withdrawing patient, there is a decreased total exchangeable amount of magnesium present in the body. And I think that it would be important not to use doses of magnesium as far as a sedative, but just as replacement therapy, that this in itself may have a great deal to do with the recovery as far as the medical management.
What dose are you talking about, Jim?
2 cc's of 50% solution given 2 or 3 times a day for the first 2 to 3 days. Normally the hospital diet contains sufficient amount of magnesium that thereafter the total exchangeable amount once again returns to the normal.
I'm glad you mentioned diet, because I think one thing that sometimes may be overlooked in the general hospital is that the rather erratic eating habits of these patients and their need for some fairly substantial available calories and fluid and fruit juice intake in this first 72 hours.
Well, this has been a really stimulating and intriguing discussion we've had. I've learned a good deal. I hope perhaps the panel has too, and I hope you have. I want to simply close by thanking the members of the group. Drs. Knott and Beard from Memphis, Dr. Fox from Atlanta, Mr. Stern from the city of New York. Thank you very much.